All right, good morning, everybody, and welcome to this round of lectures. Today we're going to be doing drownings and cold emergencies. That's going to include ice water immersion as well as some of the common skin complaints and hypothermia. So we've got a lot to cover. Let's go ahead and get started. I can get the slide to advance. No disclosures. However, I do want to give credit where credit's due. This lecture is partially from other lectures from Captain Kevin Richards from Springfield Township, Air Evac, and my friend Doug Gallo, who is the regional EMS director in the Akron-Canton area. So today, at the end of this lecture, you're going to be able to understand submersion injury, some of the pathophysiology of these various diseases, treatment of non-fatal drownings, along with hypothermia physiology and treatment, and then some of the complications that can develop from cold exposure. So what is drowning? Drowning is considered any type of respiratory impairment from submersion or immersion in liquid. It doesn't matter if it's water, as long as it is a liquid of some sort. If you get respiratory impairment from being submerged in it, then it's going to be considered some sort of a drowning. We really divide drowning up into two categories, fatal and non-fatal. So fatal is obviously if the person dies as a result of their drowning, okay? And fatal drownings can occur even months after the actual drowning event. So if the person dies from complications that resulted from the drowning, it is still categorized as a fatal drowning. Non-fatal is if the person is rescued at any time, and that process is interrupted and they end up successfully surviving. What we want to avoid, though, is some of the stuff that you hear in the media and the layperson vernacular: near drowning, dry or wet drowning, secondary drowning, active or passive drowning, and then delayed onset of respiratory distress. None of those adequately describe any of the physiology that's going on. There really isn't any sort of thing such as a secondary drowning or a dry or wet drowning. By definition, they're all wet, and it's just we shouldn't use terms like that. It's really fatal and non-fatal. So let's talk a little bit about the statistics of this. Worldwide, there's at least 500,000 drownings each year, and that number is likely significantly higher than that. If you think about it, in third world countries, they don't have public health, and so they're not keeping track of how many people are drowning. And it may be that, some of these remote villages, et cetera, they wouldn't even have anybody to report it to. This number is likely significantly higher when you take into account the third world countries and their lack of public health. In the United States, there's at least 10 deaths daily due to drowning, and 1 in 5 of those deaths is a child under age 15. It's the second leading cause of injury-related death in kids from ages 1 to 4, and it is the leading cause of death in boys 5 to 14. For every child that has a fatal drowning, 10 more require a visit to the ER. If you're in a water heavy area, like where I was up in northern Michigan, we would see, non-fatal drownings almost every shift during the summer because somebody would have gone under or needed rescue or whatnot. And that adds up. If we just look at the cost of beach coastal drownings in the United States, it's at least $273 million per year in medical costs. And that's just with the Atlantic and Pacific and Gulf coasts. That's not including, all the little inland lakes and rivers and things like that. So as we see here, who faces the highest risk of drowning? Males are more than double the rate of females over the years. And then this really is a disease of age extremes. If you look, by far, the highest age group is that 1 to 4 toddler drowning. And then it really goes to 85 and up, 75 to 84, 65 to 74, 55 to 64. So that number dramatically increases, with age, to the point where nowadays you're either really young or really, really old. And looking down, we kind of have the rest of the age groups, et cetera, with the lowest rate being in this 5 to 14 range here, and that's including both genders. So this is the best data I was able to find recently on state by state breakdowns. So it's very interesting. California, Arizona, Texas, and Florida have by far the highest death rates associated with their states. What's interesting to me though is Ohio is right there, 13. It's the same as Alabama and Georgia, which have coasts with the ocean. I'm not sure really why that is. It's kind of surprising to me, given that I would expect in some of the more southern states there'd be more pools, et cetera, therefore more opportunities for kids to drown. But it's interesting that Ohio is right up there with the rest of some of the southern states. We do know that drownings are more prevalent in rural areas. Again, more lakes, further spaced out. It may be that somebody, is missing for a prolonged period of time before they're found, and the resuscitation begins. But, rural areas are, more predisposed to worse outcomes. So again, the groups that are at risk are males that are aged less than 14. There's typically some sort of alcohol use in a good significant portion of these cases. They may be of low income or have poor education. Again, less likely to have access to swimming lessons and things of that nature to teach people how to be safe in the water. They're rural residents. Obviously, they're exposed to, water. They may be undergoing risky behavior, may not have supervision. And then another interesting thing is seizure patients. There's a lot of seizure patients that still go out and swim, but we also have to keep in mind that this includes patients that are taking a soaking bath. Unfortunately, some of these deaths are a result of somebody with a seizure disorder taking a soaking bath and having a seizure and slipping under the water. And they're still altered and postictal enough that they're unable to rescue themselves in time and so end up, dying or having a non-fatal drowning. So what can we do to prevent this? Well, we know that 85% of these are preventable. And a lot of them, is because of supervision and swimming instruction. If we had more supervision of, kids that are at the highest risk, that would mitigate some of these deaths. If we had more prevalent public swimming instructions available, I think that would go a long way. It would teach people how to be safe in the water, and at the very least, teach them how to rescue. We also know that regulations sometimes will help with this. Most states, most counties now have some sort of regulations around private pools and public pools. For example, I think it's Ohio law that you have to have a fence, around your in-ground pool, and you have to remove access to above-ground pools, such as locking up the ladder or removing the ladder, et cetera, so that way kids can't get into those above-ground pools. Interestingly, though, regulation is not going to take care of everything. Florida has really restrictive regulations around pools, and yet they still have a very high drowning rate. So it's only part of the solution. Public education goes a long way. A lot of education dollars are spent on, telling people not to dive into water, especially when they don't know what the depth is, and to not mix alcohol and any sort of water activities. So toddler drownings, unfortunately, tend to occur due to lack of supervision. Any of us who have ever had toddlers know that you can turn your back and in 10 seconds they are into something that's really bad. It's just the nature of learning how to be a human. Unfortunately, so many of these toddler drownings are because mom, dad, caregiver, etc., turns their back on the kid, and there happens to be a pool or a lake or something, and the kid goes to investigate it, and sploosh, they go into the water. Most of these are occurring in the afternoon or early evening. Kind of makes sense. That's the hottest part of the day. It's also when families are starting to get ready for dinner, and so they're doing other things while potentially keeping an eye on the pool. And, unfortunately, only 18% of these are actually witnessed. That says that we're finding a lot of these kids when they're already in the water, in the act of drowning. Recreational boating is another big reason. 90% of deaths from recreational boating is because of drowning, and 20% of those deaths are due to lack of flotation devices. So whenever you're out on the water, highly recommend that you have some sort of flotation device. They even have ones now that are gas powered, and so they'll react with the water when it goes in, and it's like, a very thin vest type thing that you barely will notice is there, but as soon as it hits the water, it rapidly expands and floats, so that you're hopefully safer. A lot of these occur from small or open boats, such as sea-doos and pontoon boats and things like that, and tend not to occur from the larger boats. Unfortunately, again, a lot of these are also going to be, with alcohol use on board. Alcohol and water just do not mix. Diving injuries is another big thing that contributes to some of these. There are about 700 or 800 diving injuries per year. The peak incidence is 18 to 31 years of age. Unfortunately, a lot of the time, this is hold my beer, watch this. And so alcohol is related in 40 to 50% of these diving related injuries. It tends to occur with people that have no formal training, meaning they're not a competitive diver, they're not doing any special moves or anything like that. They're just going off of a tree swing into water that they don't know, and so end up hurting themselves rather badly. So let's talk a little bit about the pathophysiology of drowning. And there are a few different factors that we have to keep in mind. Hypoxia and the degree of hypoxia we get, along with how quickly we become hypoxic. Acidosis, meaning the buildup of lactic acid in our system along with carbon dioxide. And then this both leading to multi-organ dysfunction, which can make managing these patients days later very, very difficult when they're in the intensive care unit. So, in the act of drowning, the first thing that the victim is going to be doing is breath holding. So, as they go under the water, they're going to begin doing breath holding. This can actually occur for a period of time. Typically, during the act of drowning, these patients are going up and down, up and down, up and down multiple times before they finally slip under the water for the last time. Um, as they go into the water, they're going to breath hold. They're going to hold that breath as long as they can. Eventually, their body is not going to let them hold on to the breath anymore. And so they're going to exhale rapidly and then reflexively inhale. And unfortunately, that means that water has now entered your airway. And unconsciousness is going to be fairly quick after this. Just like whenever you are drinking something and some liquid goes down the wrong pipe, your larynx involuntarily spasms to try and keep that water out of the lungs. And that laryngospasm can be really intense. And so sometimes these patients will have such bad laryngospasm that no water will actually enter the lungs, and they will drown despite not really having much water, if any, in the lung tissue on autopsy. As we're, now losing consciousness, that oxygen tension in the blood is decreasing. Eventually, it gets to a point where the larynx can't continue to spasm, and so that releases. At this point, your heart is also likely close to stopping, if not stopped. And then, just like with cardiac arrest victims, there'll be a agonal breath that will occur under the water. and that will also then bring liquid into the lungs, etc. So it's a really you know nasty way of dying. In the act of drowning, patients will recognize the danger. They're initially going to, be so focused on getting that head above the water that very frequently they are not calling out. They're not making noises. They're not, doing the movie, help me, I'm drowning. They're not doing that. They tend to be very quiet. And what you'll notice is oftentimes they will be kind of flapping on the water like this. And that's because they're just reflexively trying to push up on the surface of the water like it's a solid surface, as if it were the side of the pool and they're trying to lift themselves up. And so they'll be, flapping against the surface of the water. Very frequently, their head is tilted back, again, trying to get their mouth and nostrils as close to that surface of the water as they can so that, any little bit of air that they can get, they'll get. Um, and very frequently, again, they're not making any sounds. Videos of these, from surveillance videos and things like that, show just how quickly it happens and how the pool can be full of people and somebody's drowning 10 feet away from you and you don't even know it. And it's not until the lifeguard recognizes that they went under the water that help comes. So during this involuntary breath holding, the victim is still conscious initially and continues to struggle. Eventually, though, you begin to lose, consciousness, and your reflexes will eventually override kind of your conscious thought, and you'll take this reflexive inhalation at the end. This usually lasts about 90 seconds or less. Obviously, it depends on how healthy the person is, whether they got a full breath before going under, etc. But thankfully, patients will go unconscious relatively quickly, so they're not experiencing, the rest of this. They slip into unconsciousness. At this point, there's no movement of the arms and legs, and they're going to begin to sink. However, the rate at which they sink depends on a bunch of things. It depends on the body itself, how full the lungs are when they are going underwater, if they're wearing any kind of equipment, etc. And then also the salinity of the water. We know that salt water keeps people very buoyant to the point where I've had friends that have been to the Dead Sea and they say it's very weird going out on the Dead Sea because it's like half your body is out of the water when you're used to, the majority of your body kind of being right at that surface level. The salt is so high that people are really, really, really buoyant. Pool water, on the other hand, is, very similar to just plain water. And so patients can sink relatively easily in that. Some patients during this unconscious phase will have some hypoxic convulsions, very similar to when somebody, passes out. Sometimes when they go down, they will have a couple of seconds of that jerking motion, that myoclonus. It's not a seizure. It's just due to a lack of oxygen in the brain, and it only lasts for a couple of seconds. Sometimes when these patients are pulled out, they can appear rigid or stiff. Additionally, they sometimes will be frothing at the mouth, because of the liquid they may have aspirated during this phase. And then clinical death begins to set in. Obviously, if we can't get breathing and circulation restored quickly by CPR and advanced life support, unfortunately, people die from drowning. Sometimes, we will get these patients back in the field, only to have them die weeks or months later from complications as a result of the drowning event, which is, even more tragic. It just prolongs kind of the whole process. So the results of the hypoxia that is occurring from the lack of oxygen is we begin to produce lactic acid, just like every other, oxygen deprived thing. In addition, the carbon dioxide begins to build up in our system, causing carbonic acid, which further lowers that pH. As that pH lowers, our metabolism isn't able to function the way it's supposed to. Humans have a really narrow band where our enzymes and things like that will work. As we get lower in pH, they don't work the way they're supposed to anymore. This leads to your heart having, dysfunction or irritability. Eventually, it leads to cardiac arrest. And then throughout this whole process, it's varying degrees of brain ischemia. And so, unfortunately, a lot of these patients will have lasting deficits. The other thing that can occur that makes resuscitation more difficult is all of us have a chemical in our lungs called surfactant. If you remember from any of your neonatal resuscitation stuff, surfactant is this substance that keeps our lung tissue there, um, very slippery and keeps the lung and the alveoli from kind of collapsing and becoming stuck to one another. So it allows us to then balloon back that air sac. However, as we get water into that area, we dilute out that surfactant. And so all of a sudden, we now go from having slippery lungs to very sticky lungs. The mucus that's present also tends to absorb additional water. And so the mucus secretions will become thicker even if there's no extra mucus having been produced. All of this leads to an inability for us to exchange gas across that membrane. It also makes it more difficult for us to keep those lungs inflated. Bagging these patients can sometimes become difficult because the lungs are waterlogged and they're now sticky and clogged with mucus. And so it can make managing these patients on a vent very, very difficult. So what's the prognosis of these folks? Well, those that we find that are awake or just mildly confused, et cetera, are going to have a better outcome than those that we pull out comatose. Unfortunately, 35 to 60% of those requiring CPR die. And like I said earlier, 60 to 100% of the survivors experience some sort of long-term neurologic complication. It can go from, short-term memory loss to being, completely dependent upon a ventilator for the rest of their life, et cetera. So some of the other factors that affect outcome is obviously the younger and healthier the person is, the better their prognosis. The water temperature really matters as you get colder, and we'll talk about that here in a little bit. What the water is. Is this water? Is this sewage? Is this some industrial chemical, that they fell into, et cetera? That's gonna change the damage to their lung tissue. Do they have any other associated injuries? Was this a diving accident as well? And so now they've got a cervical spine injury. And then, the type and timing of that rescue and resuscitation. If it takes us forever to get this patient out of the water, that does not bode well for that patient. The quicker we can get them up and out and get circulation reestablished, the better the chance that person has for a good outcome. So, what's our pre-hospital treatment? Well, it really focuses on a bunch of the standard kind of stabilization things that we do for any sick patient. First, we got to get them out of the water, and that requires training typically. Luckily, a lot of area departments have folks that are qualified to be able to do this water rescue stuff. We then have to, kind of ask ourselves, is a C-spine injury suspected? If it is, we probably ought to put this patient in a collar and, get them out of the water. But we don't want to let that C-spine injury distract from our need to get an airway. So if we have somebody that needs to be intubated and we're not able to do that with a collar in place, remove the collar, get the airway established, put the collar back on. That way we can facilitate getting that airway going. Um, we want to start doing rescue breathing, and if this patient is hypothermic, and I mean very hypothermic, we may need to check for a pulse for quite a bit of time because their heart rate may be so bradycardic that they're beating 20 or 30 times a minute. Um, Almost to a rule, these patients are going to be some degree of hypothermic, even if it is just simply they're being pulled out from a heated pool, etc. Those heated pools are kept, 80 to 90 degrees Fahrenheit, still lower than human body temperature, but then we also are pulling them out wet. And so their bathing suit, their clothing, whatever, is going to be wet, and we're going to begin to lose heat from that evaporation that just naturally occurs. At one point, it was taught that you could try doing a Heimlich maneuver, to get the water up and out of the lungs. We now know that's ineffective. So don't bother trying to perform a Heimlich maneuver. Water may come out if you are doing CPR, etc. But it's not a huge barrier to the resuscitation that we need to do to get that heart going again. So if we pull them out and they're altered, we still need to think about other causes of altered mental status. Are they, hypoglycemic, which contributed to this? Did they have a seizure, et cetera? Try and clean out their airway. If they need supplemental oxygen, get them on supplemental oxygen. Some of these patients may benefit from CPAP or early intubation. The CPAP, just like in congestive heart failure, helps to keep those alveoli, popped open and, less sticky. So that can help us oxygenate much better. Some of them may require rapid volume expansion, especially if their heart is, still somewhat shocky from being hypoxic. And then sometimes we need to use pressors. I've got a couple of pressors listed there, but for us, we're primarily going to be using push dose epinephrine. So refamiliarize yourself with how to mix up and administer some push dose epinephrine. So let's talk a little bit more specifically about cold water drowning. I really wish that this was actually more called ice water drowning. Um, Around here in Cincinnati, it's highly unlikely that we are going to have anybody that is a true cold water drowning or ice water drowning. Lakes that are in the 40 degrees range do not have nearly the same protective benefits as a lake that is, 32 degrees, has ice on it, etc. Um, we know that the factors that lead to successful resuscitations of these folks is how quickly they become hypothermic and how quickly that metabolism slows down. If this is a very slow process, that means that the tissue is ischemic and not functioning properly for a prolonged period of time. That releases toxins, that causes damage, etc. Whereas if we're immersed in, ice water, essentially, that ice water very quickly cools us, which slows our metabolism down and, basically gets us into almost like a suspended animation state. And so our metabolism has slowed significantly. It doesn't get nearly the level of ischemia. It doesn't produce nearly the amount of toxins, et cetera, and can provide some neuroprotective benefits. Additionally, humans are mammals, and all of us have this mammalian dive reflex. This is a natural response to cold water, and it slows the heart rate down and slows our metabolism down because we need to preserve what little oxygen we've got so that we can go down and capture our fish or our shrimp or whatever it is that our body thinks that we're down under the water doing. Um, these folks, ideally will be severely hypothermic. They may even appear dead with profound bradycardia, and they may have significant vasoconstriction. Depending on how cold they were, you may need to check pulse for 60 seconds or so. I probably would err on the side of doing CPR on these folks rather than taking the full 60 seconds. But sometimes they'll be so bradycardic that it can be very difficult to feel for a pulse. Hypothermia, though, can be caused by a bunch of other things. Obviously, today we're focusing on the environmental causes, but we also have to keep in mind that hypothermia can be caused from sepsis, from brain injuries or bleeds, age. It's why, old people tend to have their houses, wickedly hot during the winter. It's because their body isn't able to regulate its temperature as well. It's also why infants need to be kept warm, and we need to keep them bundled up, etc. Their body has not developed enough yet for their body to regulate its own temperature. Some toxins will do this, where they'll make people hypothermic. And then also, if somebody has decreased metabolism, either because of thyroid levels being out of whack or if they're hypoglycemic, it means that the cells don't have enough energy. And so without energy, you can't produce heat. So the body becomes cooler as a result of this. So let's define the degrees of hypothermia. So somebody that has a core temperature of less than 95 degrees is a low core temperature. Somebody that has mild hypothermia is 90 to 95 degrees Fahrenheit. And these folks typically will have normal mental status. They typically will be shivering. Um, my experience has been whenever I get this cold, I tend to be a little agitated, but it's just because I'm miserable. Moderate hypothermia is when you've now slipped into that 82 to 90 degrees Fahrenheit range. And at this point, you've now typically got some altered mental status, and there's no shivering. So these folks may have repetitive questioning. They may not know where they are, who they are. They may be asking off the wall questions, that kind of thing. And then as we get colder, we develop severe hypothermia, where we're now less than 82 degrees Fahrenheit. At this point, the patient's unconscious. As they get colder, they may become pulseless. And then severe plus hypothermia is when they're in that 56 to 75 degree range. At this point, these patients are going to appear dead, and there may be resuscitation possible. These folks, when they get this cold, are very, very difficult to rewarm. And so our ability to rewarm them and get circulation reestablished, et cetera, is going to be extremely difficult. There are cases where patients have been brought back from very, very cold temperatures, but it's kind of the exception, not the rule. Death is if you've now reached less than 56 degrees Fahrenheit. At that point, you are so cold that we are not going to be able to resuscitate you. And you have likely had your metabolism shut down for so long to get to a temperature like that, that the tissue is essentially dead at this point. Obviously, if somebody is frozen solid, they're not resuscitatable either. So how do we become hypothermic? Well, there's a bunch of different ways that we lose heat. Conduction is when you're directly sitting on something or leaning on something, etc., and that other item is now sucking heat from you. The best example of this is anybody who sits on the ground and it's concrete knows that your butt is going to become cold and you're going to become achy and sore pretty quickly because that concrete is really good at sucking the heat out of your body to warm itself up. Convection is when we've got air currents that are passing across the body. It's, wind chill. It's also why standing in front of a fan when you're hot works so well. That air is actually pulling some of the heat away from your body. We also have radiation. Our bodies are constantly emitting infrared rays. So literally we are glowing. It's just our eyes are not able to see that infrared ray. But just like in the movies The Predator, etc., that infrared radiation, etc., is taking heat away from us. Evaporation is also incredibly important. As the water evaporates, it has to undergo a phase change. It goes from a liquid to a gas, and that takes heat. So it takes heat away from you. It's why we sweat. It's why standing in front of a fan when you're hot and sweaty feels so much better. You're not only getting that convective heat loss, but now you're allowing better evaporation of that sweat to occur. And so it takes even more heat away from you. And then respirations. There's not a whole lot that we can do for respiratory heat loss, but it does combine convection, radiation, and evaporation. It's why when you inhale, you don't see any gas, but when you exhale in the winter, you will see, the vapor cloud, etc. And that's unfortunately just taking heat out of your body. So this is just a graph, or I'm sorry, a chart, kind of summarizing all of the various temperatures and their states. So we need to conserve heat. So the body has several mechanisms. What's interesting though is, these Bernese mountain dogs that all of us have seen in cartoons, et cetera, that have the little barrel full of, alcohol around their neck, et cetera. That's actually bad. I can't remember what those barrels were supposed to be filled with. I think it was brandy, but I'm not positive. Um, One of the ways that our body copes with cold is we vasoconstrict our blood vessels. Our extremities have a whole lot of, blood in them. And typically during this, we're not exerting ourselves significantly. And so we want to shunt all of that warm blood back into the central core to keep the organs happy. So our extremities are going to begin to vasoconstrict. Our skin is going to begin to vasoconstrict as well. And so these patients will become varying degrees of pale initially. Alcohol, unfortunately, is a vasodilator. It's why if you're drinking heavily, you always feel really hot. Your core temperature is probably exactly where it normally is. The difference is that this has vasodilated your skin, and so you'll become flushed and begin losing heat. Whether or not they were intending for the brandy to make the hypothermia experience more enjoyable, or if it was just a misguided attempt to make people warmer. Either way, doesn't sound like a bad day. Goosebumps are another way that the human body begins to react to cold. When we were significantly hairier, these goosebumps, et cetera, allowed our fur, essentially our hair, to stick out more. And so we essentially increased the thickness of our insulation. The way insulation in homes works is it prevents airflow. We take up voids so that air cannot flow through things because again, moving air is going to move heat. So insulation works by trapping air that now can't move and prevents it from experiencing significant heat loss. Goosebumps are doing the exact same thing. Our hair stands on end, and that disrupts airflow so that hopefully more air sticks around next to our skin and provides some degree of insulation. Additionally, our body is going to begin producing more heat in an attempt to, stay warmer. It's why the patients that are out skiing all day or are mountaineering and things like that require thousands of calories of food a day, and it's because a lot of that energy is just being burned to keep warm. So they'll increase their metabolism. They also will begin to shiver, so that way you're not really moving, but you are. Shivering is, working your muscles, and that extra work requires energy, which again releases heat. And so our body is trying to compensate for that heat loss. So there's some different ways that we can rewarm patients. Some of the things that we talk about are warm IV fluids. Well, one of the problems with warm IV fluids is we don't really in the field have fluid warmers, like we do at the hospital. Some places do carry portable fluid warmers, but the old trope of taking a couple of IB bags and throwing them up on the dash while you're on your way to this ice emergency and putting the defroster on full, okay, yeah, it's going to warm it a little bit warmer than, potentially the cab. But unfortunately, it's not going to be enough to really make a ton of difference. The pipe or the tubing, is what, 5 feet or something like that. So that's 5 feet of this liquid now transiting down to get into the vein, and it's losing heat that entire time. And so by the time it gets down to your vein, it's probably back to cab temperature again. They do make, portable warmers that you can use. But again, they really need to be an IV tubing based thing. Even, putting hot packs and stuff and taping it to the side of the IV bag really is not imparting enough heat to make it all the way down to the vein through that long tubing. Places that deal with this on a regular basis, especially like remote and wilderness rescue organizations, there are multiple different ways of warming IV fluids, including some that are charcoal based. Personally, I don't know that I would want to be in the back of an ambulance with a charcoal warmer going, but I've literally seen them advertised. When we get them to the hospital, we can begin doing additional active rewarming with gastric lavage, where we put a tube down into their stomach and we'll flow warm water down and suck the cold water back out and keep repeating that process. We can do the same thing with their bladder. We'll put a catheter in and fill their bladder up with warm water and then pull out the cold water and continue to do that. One of the best ways of rewarming a patient, though, is through ECMO or bypass. Again, because of the amount of heat that is lost when you take the blood out of the body and put it in piping, that all becomes a big radiator. And so all of these bypass machines have built-in warmers so that way the blood is returning back to the body at body temperature. So we can use that ECMO device to begin warming their blood and circulating that blood around, which is going to rapidly begin to improve their temperature. Unfortunately, drugs and defibrillation likely are not going to be effective until they've hit around, I think the current consensus is 88 to 90 degrees Fahrenheit. Below that, you can still try it, but it's not likely to be successful because, again, the metabolism is so messed up at those lower temperatures that it's unlikely to actually do anything, at least for a prolonged period of time. Some of these patients, when we get them, are hypothermic, and we will see a J wave or an Osborne wave. And as you can see there, it's kind of this little, out peninsula, off of the QRS complex, etc. It sometimes can be mistaken for an ST elevation. It's not a T wave though, so it's not ST elevation. And again, it's buried within that QRS complex. I've seen it a few times. The times that I've seen it have been when patients are really cold. This is not somebody who's like 92 degrees. This is somebody who's like 85 degrees. When I've seen it, it's been somebody who went through the ice, or somebody who was out in a snowbank for a prolonged period of time. So how do we manage hypothermia in the field? Well, the first thing is we've got to get them to a warmer environment. So get them into, the cab of the truck as quickly as we can. Try and get them out of their wet clothing. Again, that wet clothing is allowing evaporative heat loss to occur. And so we need to get them out of that wet clothing and get them dried off. We want to prevent further heat loss. Since we don't have great ways of rewarming patients actively in the field, we need to prevent their hypothermia from getting any worse and allow their body to kind of reheat as much as it can on its own. My typical recommendation is, you get them out of their wet clothing, get them dried off, and then wrap them in a space blanket. After you've wrapped them in that space blanket, you then pile a bunch of regular blankets on top. The reason I say this is those space blankets are essentially a plastic kind of thing. So that prevents further evaporative heat loss from any moisture that's left on their skin. They also are shiny, and so that's reflecting some amount of the infrared rays that their body is producing. And then we put on top of that the other blankets. And the blankets are again basically just like insulation. It's trapping air that doesn't move against the space blanket so that we're not losing any convective heat loss either. If you've got somebody who is mildly hypothermic, they probably don't need that space blanket, and regular blankets are generally enough. We do want to minimize any rough handling. The colder they are, the more irritable their heart will be. And so there are case reports of patients going into ventricular fibrillation from, rough extrications. We want to try and monitor their temperature. Obviously, in the field, we don't have a lot of those invasive monitoring devices such as rectal probes or Foley catheter probes or gastric probes, etc. But we do want to try and get some sort of a temperature on them. Under the tongue is acceptable. I probably would not do any of the axillary temperatures, etc., simply because that skin is vasoconstricted from the cold and is likely going to give us a falsely lower number than their actual core temperature. Please get them on a cardiac monitor. Again, this is going to allow us to see how irritable their heart is, see if we see any of those Osborne or J waves, and allow us to, intervene if they do go into VFib. If we are one of those, locations that does have actual IV fluid warmers, we want to start using that. Otherwise, honestly, it's just get room temperature fluid going into them if they need it. What we don't want to do anymore is put heat packs on the patient. There are numerous case reports of these heat packs burning the patients. Even though they are not in and of themselves, hot enough to cause physical burns, heat, regardless, begins to break down the skin. And so there are lots of cases of kind of this secondary burn occurring. Their skin is numb, it may be frostbitten, and so they have no sensation left in it. And we put that heat pack there, they're not going to feel the discomfort of their skin beginning to break down, et cetera. And so we don't recommend putting heat packs on the patient any longer. Just crank up the heat in the truck and get them in the blankets. So getting them out of that cold environment, is the most important step. And then generally, mild hypothermia, all that's required is letting the body kind of rewarm itself. But severe hypothermia is going to require, more active core rewarming, etc. When we talk about, ECMO bypass, there really right now are only two facilities in the greater Cincinnati area that reliably will do this, and that's UC downtown and Children's downtown. They both have much faster and better and reliable access to bypass technicians and machines, especially during off hours, than any of the other facilities. The other facilities, while they may have bypass, for their heart-related surgeries, et cetera, they don't have the level of experience with doing this, and there may be some pretty significant delays in getting that active rewarming going. So again, some of the rewarming measures, passive is what we're going to be able to accomplish, in the field, and then after that, it's mostly going to be, hospital-based stuff such as warm water immersion, and these more, invasive means of getting the patient warmed back up. And the old adage of always resuscitate. You're not dead until you're warm and dead. There's a lot of truth to that. One of the ways that we know somebody is truly dead is, again, their temperature is probably less than 56 degrees, or we've been actively rewarming them. We've got them on ECMO, we've got them having, bladder lavage and stomach lavage, et cetera, and we reach a temperature and we can't get them any warmer after that. There's only so much heat that we can put into the human body before we start essentially cooking. Um, the body is supposed to be producing heat all the time. And once we've kind of plateaued at a given temperature, if the body is not, metabolizing and producing its own heat, we're not going to be able to get above that without causing thermal injury to the body. We just simply cannot impart enough energy into that body to get the center of them warm enough, to get things going again. So that's one of the ways at the hospital we know, this resuscitation is probably at its end. Is we've warmed them and warmed them and warmed them, and we're not getting them any warmer than a given temperature. And at that point, we know that their metabolism is so shut down that there's really nothing to resuscitate at this point. So let's pivot a little bit and talk about some of the other cold related emergencies. This is a graphic that was from World War II. If you remember, in World War I, there was a lot of trench warfare, and we didn't have, the modern technologies, et cetera, of waterproofing. Nobody had ever fought a war like this before. And so there were actually more casualties being sent home from, trench foot and other injuries like that than were actual, casualties from enemy fire. Trench foot is something that's really nasty, and we're going to take a look at some pictures. We're also going to be talking about chilblains, frostnip, and frostbite. So chilblains is this initial thing. Most of us have probably experienced this to some degree. It's when we've been exposed. It's usually going to be on our hands or other skin that has to be exposed when we're outside. And this coldness causes inflammation. It's not really freezing. It's not like frostbite or frost nip where, there's actual freezing occurring. This can occur in just cold weather. But there'll be enough of a localized heat loss that it causes skin irritation. So these folks will present with, red and purplish areas. Sometimes they will slough off like you see in this kind of healing one that's on that index finger. But it usually only causes, irritation, itchiness, sometimes a little bit of pain that resolves then in about 2 to 3 weeks. So the way we treat this is get them dry, warm up the affected areas, and then they can keep them elevated. When we see this in the emergency department, we'll talk about frequent wound care if any of them open up, which is again not super common. We'll also recommend hydrocortisone cream or Benadryl creams to help with the itchiness from the inflammation that's occurring. I really only tell people to use oral Benadryl, for the itchiness at night if they're desperate. But most of the time, this is a very localized thing. It rapidly gets better on its own and just basically needs symptom control. Trench foot is, a potentially life-threatening thing. Unfortunately, we see this all too frequently in the homeless. Essentially, what happens is their feet get wet, their socks and shoes, etc., have gotten wet, and it's cold. It may or may not be below freezing, but just simply being waterlogged and cold is enough. So the skin becomes really swollen with all that extra moisture that's there. And then the cold also begins to affect the metabolism in that area. And so we'll begin to get swelling, trying to warm the area back up. It may be numb because of the swelling that's occurring along with potential nerve damage. Sometimes it'll be very painful. Sometimes in more severe cases, they'll get blood-filled blisters that will begin to form from the skin layers essentially separating. Unfortunately, that can lead to open wounds, and those open wounds can then get secondarily infected. Obviously, when that occurs, we've now got an infection in addition to the other tissue destruction that surrounds that area. It's rare nowadays, but sometimes, we still need to do amputations because of secondarily infected trench foot. But luckily, most of the time, we're able to get these folks, warm and dry and a better housing situation, et cetera, to salvage kind of their extremity. Frost nip is something, again, that most of us have experienced at some point during our lives. Typically, for me, it's been when I'm either outside skiing or outside shoveling snow. This really is more of a temporary paresthesia to our extremity that resolves with rewarming. And so, it's that whole my hands have now become meat hooks because they're so cold and stiff that I can't really feel them anymore. That's frost nip. As it rewarms, it can be somewhat painful, and that's just simply everything kind of waking back up. But it does not leave any permanent damage unless you happen to injure yourself because you can't feel your extremity. But generally, this is not going to cause any type of permanent damage. Frostbite, unfortunately, is the progression of all of this to where the tissue is now actually freezing itself. Frostbite occurs because as water freezes, it forms ice crystals. And inside cells, those ice crystals are like a million different daggers kind of stabbing outside the cell and breaking up that cell membrane. And so you get pretty significant, tissue damage. The longer somebody is, frozen, the worse that injury is potentially going to be because, again, the deeper those ice crystals have formed, the more solid those ice crystals have formed, and more likely they are to cause permanent tissue loss. A lot of times here in the United States, we see this again with psychiatric illness, homelessness, alcohol and drug use, where people are not in the right state to understand the severity of the cold that they're experiencing. Lots of times we will see this in mountaineers as well when they're ascending. It's kind of very common if you're going to any of the really high mountains that you're probably going to come back with one less digit at least on your way back because it's so hard to keep yourself warm at altitude. So very similar to how we kind of grade, burns. We have, frost nip, which is kind of that superficial layer of skin has gotten irritated, paresthesia, et cetera. That's like the sunburn. Okay, so that's the cold related version of a sunburn. Then we get into superficial frostbite, which is more like those partial thickness burns, where it's now involving the deeper tissues of the skin, but we haven't quite gotten into the, fat. And then deep frostbite is that third degree burn. This is where we've got full thickness of the skin, now including some of the, tissue below the skin that's now getting frozen and damaged. One of the things that is paramount whenever we're taking care of frostbite is the old adage of if it freezes in December, you're not going to remove anything until May. Even though this guy's hand looks absolutely horrible and looks like he's going to lose every one of those fingers, that may not be the case. If we were to cut him off right now, we could be cutting off perfectly viable tissue that's hidden underneath all that black skin. And keep in mind, the more we take away, the less prosthetic we are able to really work with. So typically what we will do is we'll have these patients, keep these digits or extremities, et cetera, from refreezing and keep them clean and dry. In this case, they're using betadine on this to keep the tissue dry. It literally will remove some of the moisture from the affected dead tissue. And it also has the effect of killing off any bacteria that may be trying to get in through that dead tissue. Unfortunately, if gangrene becomes infected and it becomes wet, at that point, then we sometimes do have to take off more tissue than we want to because we've got to get rid of that infection. Obviously, this tissue that's black is not viable. It does not have an immune system to fight it. And so it's basically just, food for the bacteria. So we need to, sometimes get that tissue off and deal with whatever we have left over. Hopefully, in a situation like this, the area where we see that really well demarcated, et cetera, hopefully underneath that black area there, at least some of that first knuckle is going to be able to be salvaged, so that they have at least a little nubbin that they can use for prosthetic. Prosthetics have improved drastically over the last 20 and 30 years. So even just a little nubbin is sometimes enough for us to fit a good prosthetic that can then give them um, pretty good functioning from it. So even though this guy looks horrible, if he came into my emergency department, I'm going to say, hey, this actually for frostbite looks pretty good. It's not wet. It doesn't look like it's infected. We just need to keep it clean and dry, and have you follow up with the hand surgeon here in a couple of weeks to just make sure that it's continuing to look good. And then, after a few months, all right, we may be to a point where we kind of have declared how much of it is going to be salvageable, and we'll debride off any of the dead tissue and repair whatever we need to repair. So when we're responding to any of these kind of ice emergencies, et cetera, we need to get some history from the people that, called it in or witnessed this. Where were the victims last seen? What kind of clothing were they on? What kind of water environment are we dealing with? Is this a flooding situation? Is this a cold weather situation? Is it moving water? Is it still water? What kind of stuff is in this water? Is it day or nighttime? And all of this is going to direct what kind of resources you need to get to the scene, whether that be boats, dive teams, extra lighting. Nowadays, we've got the drone teams that can come out and do wide area searches with infrared, much better than we're able to do, especially at night. So get the right resources coming to you while you're kind of gathering the necessary information. Some things that we have to keep in mind when we're kind of getting a plan together is we've got to keep in mind that there are a lot of these water bodies um, have some sort of human intervention done on them, whether that be a low head dam, a strainer, bridges, flood control basins, etc. Those are all potential danger spots that rescuers may have to contend with. So it's important that the rescuers understand what they're going into and understand where certain things are located so that they can hopefully avoid those areas. Sometimes you also have the ability to shut the water off. Sometimes there is a dam upstream, and you can get a hold of the Corps of Engineers or whoever owns that dam and have them temporarily shut the water off so that you can get a much better or safer extrication done. So when we're dealing with an ice rescue, these are almost universally going to be an advanced life support run. We need to, assume that these folks are going to be hypothermic. We know that that cold water sucks the heat out of them 25 to 30 times faster than air. And then we also need to keep in mind, is this something where air care may be beneficial? If they are profoundly hypothermic, even if they may be in cardiac arrest, air care may be willing to transport that person with the Lucas device in place to get them down to ECMO so that they can get rewarmed. So keep that in mind when you're kind of developing your plan. Some of these survival factors for ice water rescue is, obviously the water temperature, the length of time that they're in this water, how good the quality of CPR is, the age, etc. Again, one of the things that protects people in ice water immersion is how quickly they get cold. It's not that the water temperature itself, it's how quickly that water temperature sucks the heat out of them to prevent that hypoxia. So some of the victims that we're going to come across are potentially ice fishing. We don't really see that around here. Kids playing, skaters, sledders, snowmobilers. Unfortunately, we all too often will see, elderly, where some dementia patients, just like autistic patients, will unfortunately be drawn to the water. It's interesting to them. and they will wade out into the water, lose their fitting, and go under the water. And even though it may not be ice water, it's cold enough that they get hypothermic very quickly, and may end up, dying. So unfortunately, got to keep in mind that we sometimes will get these folks wandering away from their care facilities, et cetera, and need to look at bodies of water that are nearby because they may have gone into that. Again, substance abuse, hold my beer, watch this, is always a factor in basically any kind of trauma, and this is considered a trauma. All right, we're going to very quickly watch a portion of this YouTube video of a guy who is certifiably insane, I might add. He is going to go into the water willingly, and we're going to be able to see his kind of reaction um, to this. And pretty much all of the um, cold water immersions are going to have a very similar kind of response. Okay. And I'm assuming you guys can still see the web page. Give me just a second. I can fast forward a little bit.
To our body physiologically when we fall through. We're going to show you that that physiological response can be mitigated. Then I'm going to display how to get yourself out of the water. Once I'm up on the ice again, I don't want to immediately stand up. I already know that the ice in this area is thin, so standing up could very well plunge me back into the water. Instead, I'm going to stay on my belly, crawl forward until I'm far away from where I fell through, and then slowly get up onto all fours. And when I feel that I'm at a place where there's thick ice again, I can stand and make my way to shore. You'll notice when I fall through the ice that my arms are going to go out, my legs will also begin to spread. I'm trying to slow my descent through the water to not get full submersion if possible, because there's also a gasp response. If my head goes under and I'm unable to hold my breath, I can inhale water and begin the drowning process. So I'm trying to keep myself from going under all the way. I'm going to reach for the nearest ice shelf. I'm going to bring myself over to it, and then I'm going to do my best to just realize that within 4 minutes at the longest, this cold shock response will pass. I will again be calm, relaxed, and able to bring myself up and out of the water. With that mindset, I'm able to mitigate that cold shock response and be in a much better position to effectively kick myself up and out of the water. Okay, so this is the cold shock response, which really can be mitigated if you just relax and realize that it's going to pass, and that after it passes, you'll be able to do the second part of your self-rescue. So I spread my arms out so that I didn't get fully immersed in that gasp response. Didn't make me inhale water. So I've survived my cold shock response. Now to get out, instead of trying to pull myself straight up, I'm going to start to kick my feet and raise them up behind me. And then kick. Until I'm on flat ice. Now I don't want to stand up now. I'm going to ease myself forward. Until I feel like I'm on stronger ice. Test it and start to move towards shore. So I'm going to go in again just to show from a different angle that kicking. So again, we're kicking our feet, raising them out behind us, and then kicking forward off the ice. So kicking my feet until they come up behind. And that's what brings me safely onto the ice.
So, like I said, the guy's committed to his craft, I guess, of educating people. I sure as heck wouldn't get into water that cold, but that's just me. But you got to see their kind of that gasp response that folks will have that unfortunately can lead to some of these folks drowning. Where I was on the dive team in Michigan, one of the things that we would do every year is help out the polar plunge. And up there, we get real ice, like you can drive cars and stuff on it. So we would go out, we'd cut a hole in the ice strong enough that a bunch of people could be standing on it, and people would literally then jump into the essentially pool that we just made. And really, our job as the dive team was to keep their heads from going underwater because that gasp response is, really, really, really intense. And if their mouth is under the water when they do that gasp response, they're going to aspirate. So we would keep their heads above water and then rapidly try and get them out of the water so that they could get dry. It's important to remember that there is no such thing as safe ice, especially here in the greater Cincinnati area. We do not get cold enough for a long enough period of time to develop ice that is, able to be ice fished on or anything like that. You've got to have a prolonged, really cold time in order to get that kind of ice formation. Um, we're going to go through now a couple of the different kinds of ice, more so that you have some awareness level of it. The first is Fragile ice. Fragile ice is basically a bunch of crystals that are not necessarily interconnected. And as you can see there in the bottom graphic, it looks like a bunch of almost like pencils that are kind of arranged together, but the pencils are not connected to one another. Bunch of candlesticks kind of thing. This is very, very, very weak ice because nothing is connected to one another except very loosely. And so any type of pressure on this is going to cause it to, fall apart. Sometimes there'll be a thin, oily film almost appearance on the surface, which is those crystals beginning to form. So this ice is extremely dangerous. Clear ice is the best kind of ice. Clear ice is what forms when that fragile ice is able to continue to crystallize, et cetera, and it forms into a solid block. So now instead of a bunch of smaller crystals, we essentially have one big crystal of water that we can see through. Sometimes the ice will take on the color of the water. So you'll see all kinds of different waters, blue, green, simply clear, etc. This is the strongest ice that is formed because, again, it's one big crystal. And so you're not dealing with a bunch of smaller crystals that are not interconnected. This also really only forms when you've got those long, hard freezes. And it will freeze very, very thick. Snow ice is, similar to fragile ice. So this is where you've got clear ice that has formed, and then you get a snowfall that occurs. That snow is somewhat of an insulator because, again, it's mixed with air. And so what will happen is the snow, is going to melt some during the daylight hours. And then at night, it's going to refreeze. So it's going to go through this melt and freeze cycle, etc. And you'll literally be able to see layers develop almost like cake layers, as you can see in the picture that we've got there. This ice is very weak, and it can actually make the clear ice underneath it weak as well. The reason for that is because of that insulating effect, that clear ice isn't able to get as cold as it otherwise would. And so the clear ice isn't building up the way it normally would, and will thin out some. What they typically will do, where they're trying to use ice for, recreation, or, up in Canada, they have, I mean, there's a whole TV show, Ice Road Truckers, where they drive these semis across frozen lakes. If you notice, they're using plows on a regular basis. They're plowing the snow off of that clear ice because they're trying to get that snow off because it's providing insulation. They want to get that clear ice as thick as possible because that's what's actually supporting the weight of things. So they'll plow the snow off of the area and allow that clear ice to thicken up more. Layered ice is typically found where you've got water movement and it's various sections of ice that have broken apart and are now kind of clustered up and layered up on top of one another. It'll have sort of a striped appearance, almost like that snow ice appearance. This is dangerous as well because again, it's not one big ice crystal. It's multiple different layers that are not necessarily connected all that well. Unfortunately, some of the bigger ice sheets, etc., will also have voids underneath them. So we see this a lot where we've got a strong wind coming off of Lake Michigan, etc., and it'll push all these sheets of ice up against one another, and people will go out and start climbing on them. Well, they're not knowing that there may be a huge void of air in there, and so now not only do you have a hypothermic patient who's gone through the ice, but you've got to get them out of this void, without getting anybody else injured. The ice strength and thickness varies from one location to another. The greater the depth, the more likely ice is going to be able to form because the Earth is pretty close to isothermic down at the bottom of this area in a normal pond. It's about 39 degrees Fahrenheit. And so what's happening is the water is kind of recycling. It's going from the surface that's 32 degrees back down to the 39 degrees and continually getting reheated. Well, if that distance is far enough, then it's not going to have a chance to get warm enough, and that's when you get ice beginning to form. So it's very important that you know kind of what the water underneath is supposed to be like, to know how deep it is and also whether it's flowing or not. Water that is flowing is much harder to form ice crystals on. And so, you've got a lake that was itself somewhat thick, getting back out to, the edge of the lake. You may have very, very weak ice there, especially if it's near where a stream or something is coming in or leaving. There are calculated maximum safe loads. Again, around here, to get cross-country skiers, you've got to have a minimum of 3 inches. And keep in mind that is 3 inches of ice that is clear ice. And that's in cross-country skiers where their weight is being distributed across that entire ski as opposed to a normal footprint. It takes a lot for us to get up into the area where we can drive a vehicle out onto it. 9 inches for a snowmobile, 10 to 12 inches for a light truck. Where I used to live back in the 70s and 80s, the ice would actually get thick enough on the bay that they would plow off a big section of it, take the high school football stands and put them out on the ice, and then they would do truck racing out on the ice. From what I understand, it was kind of like drift racing that they do now. It's just with ice. But it takes really, really thick ice for you to be able to support the weights required. And as you can see, it's not likely that we're going to get ice that's thick enough here in the greater Cincinnati area for us to be able to do anything on the ice. And then this is what happens when you're not aware of your surroundings and how thick your ice is you'll go through. Um, the interesting thing about the dive team I was part of was we were part of the sheriff's office, but we were completely self-funded. Michigan has a law on the books that if a vehicle enters a body of water, it is $10,000 a day in fines after the first 24 hours if that vehicle is not removed from the water. And so the way we would self-fund ourselves is, somebody would break through the ice or go into a body of water, and we'd charge them, $2,000 to hook up the tow truck to the vehicle and pull them out. And people would happily pay that. Insurance would pay that, et cetera, because it's a heck of a lot cheaper than trying to find a dive salvage company to come out and get the whole thing removed. So we were able to buy our own equipment. We didn't take any money out of the general fund or the sheriff's fund, et cetera, and provide a lot of benefit to the community because of just simply motor vehicles. So, all right. So that is the end. I'll go ahead and stop for any questions anybody might have. Okay, not hearing any and not seeing anything in the chat. I guess we can call it a wrap. Please remember to fill out your evaluations and make sure you sign in so that you can get your continuing education credits. I'll have this hopefully posted up on my YouTube channel later today so that anybody who missed it is able to view. All right, thanks everybody. Be safe.